I am going to introduce our next speaker, Dr. Grosjean. Thank you for coming today. A little bit about Dr. Grosjean. She has worked as a psychiatrist in Belgium, then in California for over 30 years, in private practice and community hospital and nonprofit organizations geared to help vulnerable populations. She was associate professor of psychiatry at UCLA until 2016. She worked with women and men with wide-ranging struggles, diagnoses, and life journeys. She co-authored Le Manuel du Borderline, 2014, Le Manuel du Bipolaire, 2017, and Le Manuel de l'Autiste, 2022, the first comprehensive guides in French about BPD, bipolar disorders, and adult autism for patients and families. In her presentation for the 4th annual Stanford Neurodiversity Summit, she will discuss how she realized that being autistic was a key factor in her successful career as a clinician and a researcher. It also explains some of her struggles in the institutional and academic worlds.
Thank you very much, Erica. Do you hear me well?
Yes.
All right. And I will share. Well, first, thank you, Stanford, for the invitation. This was a fantastic couple of days so far. I want to thank all the participants, the speakers, the pioneers who are here, the artists, the organizer, Erica, Esperanza, Kyle. I want to thank the translators, Liliana and Noemi. Thanks to you, you're opening your work to many, many more, and it's wonderful. And thank you, muchas gracias to all of you for listening today and in the future. I will now share my screen. All right. Autistic psychiatrist, oxymoron or superpower? I chose this title because it represents everything that can be mistaken with the stereotypical representations of autism. Is autistic psychiatrist a contradiction in terms, as if we could not be both? And what about superpower? Even if it's often used with good intention, it has nothing to do with me, nor with so many hardworking autistic people who are human beings, nevertheless. Watching Elizabeth Bonker 2 days ago, however, I must say that she looks like a superhero to me. Among the stereotypes linked to autism is the belief that it is either associated with intellectual disability or with the genius of a few exceptional individuals. But between Rain Man and Bill Gates, there are millions of autistic women and men with different levels of abilities, living independently, raising children, working, or too often still looking for work. When these autistic people succeed in life and work without being identified, society is robbed of these less stigmatizing and more hopeful representations of autism. When they struggle and autism is not recognized, they, as well as their employers, are deprived of proper support. Not long ago, a doctor in training was a member of our support group, Autistic Doctors International, ADI, a group created in 2019 by Mary Doherty, who spoke here last year. Our doctor receiving the letters you see some part of here from their employer. The panel regrets to learn of your recent diagnosis of autism spectrum disorder, but since this is a lifelong developmental syndrome, which causes permanent impairment of many of the competences required for independent practice as a doctor, the panel cannot see how any workplace adaptations could now be put in place to successfully alter your outcome. There are so many errors in these two sentences. Luckily, thanks to the advocacy of ADI and the willingness of the employer to listen, the autistic trainee was reinstated. But as we see, negative stereotypes can have devastating consequences. Prejudiced by outdated theories, employers and training directors may, in good faith, discourage or deny autistic candidates access to a job that they could potentially be extremely good at. The deep-rooted yet false belief that autistic people are devoid of theory of mind and are unable to experience empathy is devastating, especially so if you consider a career in healthcare. In discouraging autistic candidates, institutions deprive themselves of the benefits of a neurodiverse workforce, not only well-equipped to help all patients, but superbly equipped to help autistic patients. Autistic patients who, through a recent research, are thought to be up to 20% of people seeking psychiatric help. The reference is here. Of course, autistic people are already in the workforce and have already been there. Contrary to other minorities who are segregated or disqualified because of their look, many autistic people are hiding in plain sight everywhere in society. And this includes autistic doctors. The majority of them, however, remain undercover, fearing that disclosure in the workplace may expose them to prejudice and discrimination. This need to hide or mask their autistic attributes comes at a high price in terms of emotional energy, burnout, depression, misunderstandings, and poor self-esteem. This painful concealment is even more sad when research shows that disabled employees who have disclosed their status were 3 times more likely to integrate into the workplace than were those who did not disclose. When an autistic doctor like me comes out to colleagues, the reaction, which is probably linked to the visceral distress associated with the word autism, is evocative of a fight, flight, or freeze response. Fight can be an irritated, "Of course you're not autistic. What's wrong with you?" Flight can be associated with a dismissive, "Whatever you say, but let's not talk about it." And freeze could be some form of obliviousness, implying, "I did not hear what you said, and we will never talk about this again." Yet, we know that when it is a peer, a doctor, a psychologist, a social worker, a nurse, who is identified as different or disabled in the workplace rather than a patient, it directly challenges co-workers' assumptions about that particular difference, and in general, for the better. I can speak today as an autistic psychiatrist because I work independently, and I no longer depend on an institution that can decide to thwart my career or deny my access to grants on the basis not of what I do, but who I am. 8 years ago, when I realized that I was probably autistic, I was the first to be surprised. How could I be autistic and have worked for 30 years as a psychiatrist? How come that time and time again I was told by friends, colleagues, and patients alike that I am one of the most empathic persons they ever met? Today, I wanted to confront stereotypes and clarify why being autistic is not incompatible with being a mental health professional, no more than being a woman, gay, or nearsighted is. In fact, among the almost 1,000 members of our group, Autistic Doctor International, the second largest group specialty is psychiatry. As an autistic psychiatrist, how do I understand autism? For me at this time, a useful description is a different way of perceiving, processing, thinking, learning, relating, and reacting to both the internal and external worlds. It is also associated with neuromuscular differences that may affect how we can, for instance, write or speak. I don't have the time to go into details, but I'd like to refer you to talks I gave, and you can find them on YouTube. Just follow the QR codes on this slide. The field of medicine is inherently and absurdly ableist. Doctors, especially when in training, are not supposed to be tired, sick, or ask for help, as if we are invincible. This is probably one of the reasons why doctors are so reluctant to seek medical care for themselves, let alone ask for a psychiatrist. Not only have many of us internalized the ableist model we were trained in, but most of the structures we depend on actively discourage any acknowledgement of difficulties, especially if we search for support in mental health. In the US, for instance, in order to renew their medical license, physicians in 29 out of the 50 state boards still have to disclose any past or current psychological or psychiatric treatment, even if the problems they consult for does not directly affect their ability to work. If you do disclose the information, it is often the equivalent of a professional suicide. These disclosure demands are in direct violation of the American Disability Act and the Federation of State Medical Boards guideline, but they still exist and contribute to a climate of terror, driving all doctors, not only autistic doctors, to hide their distress, leading them to try to fix their problems on their own, which generally is not a good idea. The result is that between endemic burnout and lack of access to care, 2 physicians kill themselves every day in America. And that is only those suicides we are aware of. This is even more alarming in the context of autism, as we know that suicide is the second cause of death for autistic adults without intellectual disability. In this climate, are we surprised that the doctor is hesitant to come out as autistic, even if this would allow him or her to get the proper accommodation to function at his or her best? And by discouraging autistic people from studying medicine, medical schools are losing the very individuals whose characteristics can make great doctors, such as attention to detail, pattern recognition, caring for the underdog, etc. Let's go a little bit into autism and neurobiology. The human brain can process about 11 million bits of information per second, 11 million. But we are generally conscious of alone 40 to 50 bits per second. It is thought that the majority of autistic people are probably perceiving and processing a higher number of bits of information than neurotypical people. This can be both very useful as well as distracting and exhausting. Autistic people generally present also with reduced habituation. For instance, they don't get used to that annoying leaf blower out of the window in the same way neurotypical do. These remain lifelong characteristics. We can also present with hyposensitivity to internal signals, for instance. We sometimes don't perceive that we are tired or in pain or hungry or need to go to the bathroom, especially if we are in hyperfocus mode. This can be great to sustain long work hours, but it can be to the detriment of our own physical health. In terms of cognition, autistic individuals often show a form of asynchronism development. The result is that some abilities may be very well developed and others less so. It is why traditional neuropsychological testings are so inadequate for neurodivergent children and adults. The range of our different cognitive abilities does look not so much as a spectrum, as a sound, but as a sound mixing board with a lot of sliders, and it is referred to as a spiky profile. As an autistic person, you may have an extraordinary memory for facts called semantic memory, but enormous difficulties in holding new information in your brain without losing track of what you're doing. That's working memory. As you see on the graph, the roller coaster type of line is the spiky profile of an autistic person, where a neurotypical person line is much more even. We also, as autistic persons, have difficulties in shifting attention, in particular when an interruption is not expected. A change that is part of a schedule, like switching from one patient to another, can be fine. It is a routine after all. Except, of course, when changes are frequent and it's absolutely impossible to focus at all, like when you have a new patient every 5 or 10 minutes. But that's not a problem just for autistic doctors. On the other hand, the ability to focus on one task or one person for extended period of times, called also monotropism, can be a very powerful tool when it comes to make difficult diagnosis, surgical intervention, or doing research. Among the characteristics of autistic functioning that are a huge plus, you can see them here: attention to details, an intuitive ability to identify patterns, make connections. Autistic people generally have a distinctive learning process, characterized both by spontaneous, sometimes exceptional mastery of complex material, and an apparent resistance. It's not resistance, we're different, but an apparent resistance to learning in traditional ways. If the teacher or the supervisor are not aware of this, misunderstanding may occur. Another difference is how we process information, in the sense of we have a bottom-up thinking, meaning we take in and process details in order to arrive to a conclusion. Non-autistic people tend to see the big picture first, the forest, before the trees. As autistic people, not immediately generalizing means that we don't always take things at face value. We are less influenced by the context and question assumptions. Temple Grandin says that bottom-up thinking frees her from preconceptions and enhances her creativity and her ability to think out of the box. Every autistic person is different, but we have some commonalities in terms, for instance, of language and social interactions. These can be considered as cultural feature of sorts. Our language is generally literal, logical, concrete, with unusual associations. The style of an autistic narrative has been described as pedantic. I must prefer to say sophisticated. We used to love words. We use fewer emotion-laden words, which is useful when you deal with highly emotional situations. We may have difficulties using the intonation that neurotypicals expect of us. Our voice or our face may not project our feelings as the neurotypical person expects us to. This does not mean that we don't have these feelings. We just express them differently. And we generally benefit from clear and written instructions. In terms of social interaction, we do not well with small talks and lacks of precision. We do not follow generally neurotypical conventional conversational rules. We have to learn them. We tend to be very honest, which can be interpreted as rude. We may have difficulties with certain type of sarcasm or to grasp that someone is joking with us. My wife wanted to be sure I added this one. We do not always spontaneously see that someone needs help, and we have difficulties asking for help. Contrary to the stereotypes, a majority of autistic people do experience empathy. They also have the ability to figure out what is happening in the head of another person based on cues, i.e., they have a theory of mind. Empathy and theory of mind in autistic people may be acquired, experienced, and expressed differently than in non-autistic people, but they exist nevertheless. Let me use my own journey to illustrate this. As soon as I began working in psychiatry, I gained a reputation of being able to communicate and collaborate with women and men that my colleagues seemed to run away from. They considered these patients difficult, non-cooperative, or even questioned that they had a real problem. Grosjean is good with these people, was my reputation. It was not always said with kindness, as my ability to succeed where they could not was met with suspicion by some, as if something was wrong with me too. Damian Milton's concept of double empathy helped me to make sense of these situations. His theory suggests that when people who experience the world differently interact with one another, they struggle to empathize with each other, to understand what's happening in the other person's mind, which makes sense. When autistic and non-autistic people interact, it was considered until recently that only the autistic person was responsible for this deficit in understanding. But communication is a two-way street. Research has since demonstrated that people from a similar neurotype can communicate more easily among themselves. The problem is about mutual understanding, or lack of, between neurotypes. This is why having a neurodiverse workforce enriches our practice for the betterment of our patients. Looking back, I believe that a number of the patients I so connected with were autistic, which explains why I was feeling at home working with them and them with me. Because empathy is so crucial in healthcare, it is important to be aware of its different components. Cognitive empathy means being able to identify cues on a face, in the tone of a voice, which allow us to understand another person's feelings and predict how they may react. It does not necessarily mean that you feel for them. Affective or emotional empathy is how we react to someone else's emotional states that we are aware of or that we are made aware of. It is when we feel for them. Neuroimaging shows that many autistic people may have, in fact, too much emotional empathy. Autistic people experience this emotional empathy. What they struggle with is cognitive empathy, in particular, identifying cues from non-autistic people. So when people were telling me that I was the most empathetic person they ever met, it is because they were particularly aware how powerful my emotional empathy was, in particular vis-à-vis patients that my colleagues had difficulty understanding or feel for. I am also capable of cognitive empathy with non-autistic people, but it has been more of an acquired skill than an intuitive one. I started working on that skill very early in life. As with many autistic people living in a mostly neurotypical world, to fit in, to belong, to succeed, I spent my life studying, interpreting, and imitating the ways other people were interacting. I had to learn it because it didn't come intuitively. These continuous scrutinizing and experimenting were not without painful faux pas. Anybody who has to express themselves in another language and culture than a different one than their native one know how exhausting and full of misinterpretations it can be. One of the reasons why my late diagnosis of autism was so useful is that it helped me to understand that the neurotypical language I use is a second language. Even if I speak it fluently, and that being in translation mode is a second nature to me, I will always keep a slight accent. But I embrace that accent not as the deficit of someone who doesn't master a language perfectly, but as the quality of a person who worked very hard to learn it well in order to better participate in the world in which I exist. As a psychiatrist, the advantage of one-to-one interaction, besides the predictability and routine, is that the relationship is scripted. It is expected for me to ask personal questions without being considered as rude. My curiosity, creativity, my ability to notice patterns, make connection, my memory, all that is incredibly useful in helping patients make sense of their own personal histories. My bottom-up thinking and neurological resistance to hasty generalizations make me skeptical, however, about rigid, all-encompassing theories from pharmacology to therapy. I also have a special relationship to hierarchy. And I did not always agree, I still do not, with the implicit academic and institutional conventions that asked us to stay silent or turn our heads aside when the emperor was walking around with no clothes. This attitude is probably one reason why my ex-chairman at UCLA, Dr. Ira Lesser, used to say, "Bernadette is no boss." For a long time, I didn't understand what he meant, as I tend to stick by the rules and think of myself as a very respectful person. My sense of ethics and my need for justice, however, in particular in protecting the voiceless, were not always appreciated by the people above me. But I'm a very dedicated worker, and during my 35 plus years of professional activities, more people appreciated my work ethic and weird sense of hierarchy than not. Or that is what I think, but I am autistic and may not always read the room correctly. It was when I was working with the homeless population in the street of Los Angeles that I first encountered this fundamental truth: nothing about us without us. The medical model has a long tradition of othering the different and is still too often racist, sexist, and ableist. In that system, patients, the others, are supposed to answer our questions, not to question our practices. In the for-profit industry that employs physicians, we are mandated to address only one billable complaint at a time and no longer consider the whole person of his circumstance. So in this culture, when burnout clinicians are confronted with a patient whose complaints they cannot understand or fix right away, the patient may quickly become an enemy, accused of not cooperating, or worse, faking their illness. This is particularly true for autistic people whose symptoms and responses to medication are often different from those we were taught in med school. The consequences of this lack of understanding are devastating for the autistic population, whose life expectancy is 10 to 15 years shorter than of the general population. This is why, once again, it is urgent not only to add courses about autism and disability in medical schools, but also to encourage the hiring and integration of a neurodiverse workforce in healthcare in general. And as often happens, change in the environment brought initially to help a few will eventually benefit everybody. Think of the cutout in curbs on the sidewalks that we all use. In biology, a culture can be understood as the conditions suitable for growth. How can we transfer this definition to healthcare and make it a place where a neurodiverse workforce can flourish? Well, a good environment is one where we have the ability to safely disclose that we are autistic, where we can have access to accommodations that are generally cheap and easy, where there are efforts to increase our co-workers of the autistic ways of being, and when appropriate, getting proper supervision, support. These adjustments are the smart thing to do and improve the general quality of work for everybody. It is not charity or favoritism. In wearing headphones while charting, is that hurting the patient cares? Hurting my colleagues or my productivity? Would anybody consider it reasonable to ask nearsighted people to remove their glasses at work in order for their co-workers to feel more comfortable? Now let's imagine that I'm asked to remove my headphones and mandated to spend my lunches in a bright rooms with lovely but chatty co-workers in order to reinforce group cohesion, when I would prefer to have lunch alone in a quiet room. I may become gradually more anxious, resentful, have an inexplicable meltdown, or simply leave my job. Everybody loses in this situation. The autistic person, the patient, the colleagues, the employers, even society, who may have to provide disability benefits for someone who is otherwise able to work in a more informed environment. Last but not least, by helping autistic people with lower level of need to stay employed with relatively inexpensive accommodations, society can free up money to fund more care for autistic people needing a higher level of support. A hospital or a doctor office that is welcoming to its workers is a place that is also more welcoming to the population it serves. This is why I want to share with you this link to a paper recently published by my colleagues at Autistic Doctor Internationals, in which you can find suggestions to create healthcare setting more welcoming to autistic patients. In conclusion, know that hopefully you believe that we autistic doctors and psychiatrists exist. I hope you will be less nervous about working with us. Please do not run away. Speak with us, ask us, work with us. After all, most autistic practitioners have spent their entire life trying to accommodate to the culture, language, rules, and peculiarities of the neurotypical world. Getting to know one another is a two-way street, but not an impossible task at all. We are different, yes, but we also have so much in common, including, for instance, why we choose this line of work in the first place, or why we are all attending this wonderful conference. When together, we communicate more clearly, respectfully, and when on both sides, we try to take in the other's perspectives, everybody benefits from it. That's the plan. Thank you.
Hi, everyone. Thank you, Dr. Grosjean. That was a beautiful presentation. I'm Esperanza Padilla. I'm a moderator here helping organizing the Q&A responses, and that's what we'll be getting to in just a moment. And I'll be keeping track of these within Hubelo as well. So if we can't capture everything here, just come with us in the Hubelo room and hopefully we can get your question there. But thank you for a wonderful presentation, Bernadette, as someone who's also actually autistic in academia. It's refreshing to have this speech. With that said, one of the questions we have within the chat is which cognitive systems are specifically impacted in an asynchronous way? This is by Betsy Johnson. I think this was a comment from earlier in your presentation.
Can you repeat which cognitive system are impacted? Is that what you hear?
Yeah, so the question says, which cognitive systems are impacted specifically in an asynchronous way?
Oh, yeah, so they don't develop at the same time, right? Can be memorizations, can be ability to make connections, can be ability to see things, interpret, process. So I will refer you to the talk I gave at UCLA, for instance, to look at that. But so that's why so many autistic children, for instance, don't speak, until 3 or 4 and then speak perfectly, right? That if you test them for speech at 2 or 3, they will be, not following the regular models. So it is for everything, but there are clearly some places where we may, like the executive memories, executive work, we have more difficulties. Also ADHD and autism are linked in a very high percentage of cases. So there are different ones, but that's why you can understand some studies, right? We're showing that autistic children in quote between 3 years old and 6 years old suddenly have an IQ progress of 20 or 30 points, just so inaccurate our studies are. So yeah, I'm sorry I cannot detail, but I hope it's clear.
Thank you, Dr. Grosjean. The next question's by Stephen Stark. What insight do you have about disclosing one's neurodiverse status in the workplace or within higher education?
I think it's extremely difficult. I can do it because, I don't risk too much, but I see tons of colleagues who are concerned, and they are, as long as there's so much ignorance about autism in people who have no intellectual disability, it's a problem. That this example, oh, you don't have empathy, you have no theory of mind, which is absurd, right? So you're not human. As long as people still, have this like stereotype and beliefs in mind, and they judge you because they are hierarchy in academia, you risk to be in trouble. So I think we need to inform. That's what I'm doing here. And so once they understand better, then they can look differently at their students. So I feel it's still risky. I heard colleagues who had, get bullies, lose their job, or if they have difficulties that anybody else would have, but the fact that they are autistic will be used against them.
Thank you for such a wonderful point, Dr. Grosjean. Speaking of which, our next question from an anonymous attendee asks, I have 2 college degrees and I'm unemployed autistic person because I can't decode and perform neurotypical behavioral style interviews. Do you have any advice for someone like me for learning this other language well enough?
Well, what I think we want to work on is, again, by increasing information. So, for instance, make sure that interviews we can be interviewed in maybe different ways than the classical ways. I think there are papers about that. And again, if we inform the employer and show to the employers, I mean, it's not magical, but we are hard workers. We have our competences. see that, okay, you know, they don't go to chit chat during the interview, and they may have, you know, the same black clothes all the time, but they can be a very good employee who is informed, and then we are us trained how to interact. I mean, the eye contact is an enormous things, right? I can better listen to you if I don't look at you, right, as an autistic person. But if the other person doesn't know that, they're going to interpret me as rude or weird or something's wrong, and may not want to hire me. So again, I think it's a lot about information at all levels.
Definitely. Speaking of which, our next comment by Olga Zorin. Olga asks, I'm interested in understanding the overlap between traits of giftedness / OEs and those of autism and or ADHD. Given your late diagnosis, do you believe standard assessments capture these nuances effectively? How do you differentiate between these overlapping traits? Is there another way to effectively and inclusively look at giftedness with its challenges in a neurotypical world if no other official diagnoses are present?
It's a very complicated question. I'm not a neuropsychologist. I can tell you that it was really illuminating to look at my own testing. I know that it challenged the neuropsychologist who tested me, because I'm already, you know, I was 59 and I learned that I've been socialized. So I don't think I'm the best qualified to respond to this question. I think it's very interesting though, and hopefully with time, we will have more appropriate testing tools, so see which one are the best ones.
Thank you, Dr. Grosjean.
Much. Thank you, everybody. Gracias.